Assalamu alaikum. Welcome to this second portion of our lecture about tumors of the ovaries. So in this second portion, we'll discuss germ cell tumors of the ovaries, sex cord stromal tumors, as well as metastasis to the ovaries. So let's start with the germ cell tumors of the ovary. So these represents approximately 10 to 15% of all ovarian tumors, but of course, the frequency to which you will see ovarian germ cell tumors will vary according to your scope of practice. The reason is that germ cell tumors affect mostly young women in their teens or their 20s. So if you have more of a pediatric or like teenager base practice, then you could see more of these tumors compared to somebody who works in a adult focus hospital, for example. So as I said, these tumors affect mostly young women, and it's very important to have fertility preserving treatments. These patients will present with amenorrhea, increased abdominal girth, acute abdominal pain due to torsion of the tumor, hemorrhage, or rupture. So the germ cell tumors of the ovaries are an heterogeneous group of tumors that will reflect the germ cell capacity of differentiating into multiple cell lines. Okay, so we will just review a few of the most important germ cell tumors. The main one is the mature teratoma, which is a benign germ cell tumor that accounts for 95% of all germ cell tumors. And it's a tumor that's derived from the fetal tissue, from the germ cells that would develop into fetal tissues. Malignant germ cell tumors that derive from germ cells that would develop into fetal tissues also include immature teratomas and embryonal carcinomas, which are more aggressive tumors. You need also to know about yolk sac tumors, also called endodermal sinus tumors, that derive from the yolk sac. They affect younger children and teens, and they present with elevated alpha-fetoprotein. This germinoma is also important to know. It is the same thing as what is called a seminoma in the testicle, but in the ovary it's called a dysgerminoma. So this tumor derives from just very basic germline tissue, germ cell tissue. It is the most common malignant germ cell tumor. It has a better prognosis because it can respond well to radiation. Choriocarcinoma can also develop in the ovary from the germ cells that would eventually develop into placental tissue. And very important to know that choriocarcinoma as a germ cell tumor is classified as a non-gestational choriocarcinoma compared to the gestational choriocarcinoma that can arise from, the real placental tissue within the uterus. Okay, so it's very important to make the distinction between ovarian non-gestational and uterine gestational choriocarcinoma because the one from the ovary, the germ cell tumor, is more aggressive and does not respond to chemotherapy as well. But both will present with elevated serum beta HCG. Okay, so let's talk about the mature teratomas, which are the main types of germ cell tumors that are benign. Mature teratoma is a tumor that is composed of mature adult type tissue that can be derived from any of the three primary germ cell layers, so ectoderm, mesoderm, endoderm. It can have different names, so sometimes clinicians will call it a cystic teratoma because they often present a cystic lesion, but they can also be solid, so it's not a very descriptive term. Clinicians can also call it a dermoid cyst, but that is actually not an equivalent terminology to mature teratoma because technically the word dermoid cyst should only be used for mature teratomas that are only composed of skin and hair. There are also mature teratomas that are mainly composed of thyroid tissue, and these are called struma ovarii. And that's an interesting entity to know because patients can present with hyperthyroidism, for example. So mature teratomas are benign, but it's best to surgically remove them either by cystectomy or oophorectomy. And the reason are first to confirm the diagnosis and to exclude the possibility of an immature teratoma, which is a malignant tumor. Also, a surgical excision allow for relieving or preventing mass symptoms or rupture of the lesion or torsion of the lesion. And finally, rarely, mature teratomas can eventually transform into a somatic carcinoma if they are left in the patient for multiple years. So the main somatic carcinoma that can arise from a mature carcinoma is a squamous cell carcinoma, but also, teratomas can transform into colonic type of adenocarcinoma, into melanomas, and so on. And these malignant transformation within a mature teratoma are very aggressive. There are a few pictures that you may see on exam. These are classic pictures. So, for example, on the left bottom side, you can see a pelvic X-ray with a bunch of teeth. And the question is, what is this? No, the patient did not swallow her teeth. What it is, it's actually she has an ovarian mature teratoma that has grown multiple teeth in it, and that's shown on radiology. On the right side, you can see an open mature teratoma that has a lot of hair with a histology section that shows, completely mature skin with hair, follicles, and nexal glands. Okay, we'll talk a bit about malignant germ cell tumors. Um, how do we diagnose them? So ultrasound, either transabdominal or transvaginal or transrectal for younger patients that are virginal, can be used to help into identification of the ovarian lesion and qualify it. A CT scan can also be used to look for SCRAD within the abdomen and also to look for metastasis into the lung. Very important concept to know is that it is very important for the diagnosis of germ cell tumor to do serum tumor marker testing. Okay, so in all young women under the age of 40 years old that present with an ovarian mass, it's very important to do these serum tumor markers because they can really help the pathologist to pinpoint the tumor subtypes in difficult case. And here's a table of the different types of malignant germ cell tumors and their potential elevation of serum markers. But what you need to remember, or the main important, are the dysgerminomas usually present with elevation of LDH. Yolk sac tumors would present with elevation of alpha fetoprotein. And finally, choriocarcinomas usually present with an elevation of beta HCG. How do we manage malignant germ cell tumor? Well, these are young patients that usually want to preserve fertility. So it's important for any patient that present at an early stage to really restrict surgery to an oophorectomy. When a patient presents already at an advanced stage with, omental metastasis or so on, then you might want to go for an oophorectomy and a biopsy of any visible disease in the peritoneum to confirm that this is a metastasis, or any enlarged nodes to confirm that there is nodal metastasis, and to confirm that this is indeed an advanced stage that will require adjuvant chemotherapy after the oophorectomy. If the patient has no desire for fertility, then the ideal surgery would be a hysterectomy with bilateral sublingual oophorectomy. However, it is quite rare in this setting that there is no desire to preserve fertility. So malignant germ cell tumors in general can be aggressive if they're left untreated, with the caveat that many of them are quite sensitive to chemotherapy and radiation therapy, and therefore they can be cured, even if they are at an advanced stage. Okay, now we'll talk a little bit about sex cord and stromal tumors of the ovaries. Okay, So these include a lot of different entities. Many of them are quite rare. So I will just focus on those that are frequent and most important for you to know about. So the main benign sex cord stromal tumor to know about is the thecomas, fibromas, and thecofibroma family. So these are benign tumors that arise from the theca cells and or the fibrostroma. And the tumor is often a mixture of both. So that's why we usually call them thecofibromas or fibrothecomas. That's also synonymous. The thecomatous component of the tumor can produce estrogens, and therefore the patients can present with symptoms of hyperestrogenism. Okay, and a very important syndrome for you to know about for your exam is the Meigs syndrome. So patients with fibroma can present with an ovarian mass that's associated with ascites and pleural effusion. Okay, and that clinical presentation really mimics a malignant process. Okay, but however, when we get in, we realize this is a fibroma and it's all benign. So this is called Meigs syndrome. And again, very high yield for your exams. Okay, the main malignant sex cord stromal tumors that you need to know about, well, first there is the granulosa cell tumor. Okay, this is a malignant tumor that arises from the granulosa cells of the follicle. And if you remember the course that we had on the ovulatory cycle of the ovary, we know that the granulosa cells are responsible to produce estrogens. So therefore, the patients with granulosa cell tumors will present with an ovarian mass associated often with symptoms of excess estrogen. Okay, so they can present, if they are premenopausal, they can present with abnormal uterine bleeding. If they are postmenopausal, then they will present with postmenopausal bleeding because the presence of new estrogen will stimulate the endometrium and kind of give a fake cyclic menstrual cycle, non-cyclic bleeding, sorry. And if the excess estrogen is high enough and long-standing enough, then the proliferative impact on the endometrium can also lead to endometrioid neoplasia. Because if you remember the course on endometrial tumors, we learned that endometrioid type of endometrial neoplasias are estrogen driven. Okay, so that is a classic presentation of granulosa cell tumors, which you see on the radiology here. The patient presents with not only an ovarian mass, but there is a thickening of the endometrial lining, and that patient actually also has endometrial atypical hyperplasia. Granulosa cell tumors can also secrete inhibin, and inhibin can be measured in the serum as a tumor marker that will help for the diagnosis, but also that can help for the follow-up of the patients. So patients, have their granulosa cell tumor removed, and then we follow them with serum inhibin levels. And if there is a spike in the inhibin level, that can identify an early recurrence of the tumor. On histology, the typical aspect of the granulosa cell tumor is what we call a Kalexner body. Okay, so the Kalexner body are kind of like cystic structure with pink material in it, and they are lined by cells that are ovoid with a grooved nuclei. Okay, so basically it makes them look like coffee beans cells. Okay, and that's also high yield for your test. Okay, if the pathologist mentioned coffee bean cells, then they mean granulosa cell tumor. Another important malignant sex cord stromal tumor that I want you to know about is the tumors that are part of the Sertoli cell tumors, Leydig cell tumors, or Sertoli-Leydig cell tumors. Okay, so these are malignant tumors that arise either from the Sertoli and or the Leydig cells that are remnants from the embryonal sex cord within the ovaries. These tumors can produce androgen. Okay, and patients will often present with an ovarian mass associated with sign of hyperandrogenism or virilization. So classic, they can present with facial hair, with male pattern baldness, and so on. When I was a resident, we had a patient um, that was brought in by her husband. One of the complaints that she had was, of course, increased facial hair, but the complaint that he had was that she had begun to watch boxing on TV and was had become like her change of personality. Literally, she was a big fan of boxing. An ovarian mass was discovered, removed it. We diagnosed a Sertoli Leydig cell tumor. Um, so she was followed up, and eventually, um, at one of her follow-up visits, the husband says to the gynecologist, "Well, you know what? My wife has started to watch boxing again, and that concerns me." And indeed, the clinicians identified intra-abdominal recurrence of the tumor that was secreting androgen. So that's just a clinical clip that can help you remember the features of Sertoli Leydig cell tumors. Okay, and finally, we'll talk about metastasis to the ovaries. So the ovaries, it's a bit like the liver and the lungs. They are really a source, a recipient for metastasis from cancers from other organs. So 10% actually of all ovarian tumors turn out to be metastasis from other sites. It can be quite a challenge for clinicians and pathologists to make the distinction between a primary ovarian tumor and a metastasis from another site. So there are a few things that can really help us make that diagnosis. Is that metastatic tumors to the ovary will tend to give bilateral ovarian involvement, while most ovarian tumors tend to be unilateral, with the exception of high-grade serous carcinoma, which tend to be more bilateral. Metastasis to the ovary will tend to be smaller than primary ovarian tumor. If you remember that picture of the very large ovarian tumor, that was a primary cyst of the ovary. And finally, metastasis to the ovary can tend to be more solid, less cystic. Frequent sites of origin will include the GI tract. So any tumor in the GI tract can have a tendency to spread to the ovary. So stomach cancer, colon cancer, pancreas, appendix is a frequent source of metastasis to the ovary. But we also often see breast cancer metastasizing to the ovary, particularly the lobular type of breast cancer. And finally, other gynecological tumors such as endometrial cancer, cervical cancer, tend to metastasize to the ovary. So as I said, it can be quite challenging for the pathologist to make the distinction. So the pathologist will often do immunohistochemical staining to try to identify the cell types. Um, so in my opinion, these type of immunohistochemical stainings, it's more important for a resident in pathology to know rather than a medical student. But for some reason, examiners really love to put questions about that on board exams. So I will mention a few of these immunohistochemical stains that you should know to be able to answer these questions and that you will notice on pathology report. Okay, so we have a few markers that tend to identify primary gynecological cancers. So for example, PAX8. When PAX8 is positive, then that's usually an indicator of a gyne origin. Cytokeratin 7 as well. And WT1 can also be positive, particularly in ovarian serous tumors. Now, CK20, cytokeratin 20, and CDX2 tend to be more positive in cancers that originate from the gastrointestinal tract. For carcinomas of breast origin, it will be mostly cytokeratin 7 and a marker called GATA3, which is a good marker of breast origin. And finally, lung carcinomas, cytokeratin 7 and TTF1. Okay, so these are markers that can come on board exams. And then you need to know about Krukenberg tumors. Okay, what's a Krukenberg tumor? It's a basically it's a metastatic signet ring cell adenocarcinoma. Okay, and I will explain what this means. It's a tumor that was named after Dr. Krukenberg, who reported the first cases, but actually when he reported them, he thought this was a new type of primary ovarian cancer. But eventually we realized that all Krukenberg tumors are actually metastases from other site. The most frequent site of origin is the stomach. So signet ring cell tumors of the stomach, particularly in young women, that will give the diffuse type of gastric cancer, will tend to metastasize to the ovary. But it can also be from other sites, for example, the colon, the breast, appendix, biliary tract, and so on. So why do we call them signet ring cells? So if you know what a signet ring is, so you have the ring itself and it has a little signet, a little emblem, uh, icon on top. And when we look at the cells, they exactly look like a signet ring. So they have a cytoplasm that is filled with a mucus vacuole to the point that the mucus push the nuclei on one side and creates kind of a signet on the side of the cell. So these tumors, they tend to look like what I call the raw potato. Okay, so they are the size of a potato, they are the color of a potato, and they are firm like a potato. When you cut it, it has this kind of gritty feeling that you get when you cut a raw potato. Okay. Um, their prognosis is unfortunately poor because they automatically signal an aggressive cancer that has spread outside of its site of origin. So, the goal of treatment is palliative. So, the ovaries can be removed, but it's really just for relief of the mass symptoms for the patient. And then patient can get palliative chemo or targeted therapy depending on where the tumor comes from. Another lesion that you really need to know about is pseudomyxoma peritonei. Okay, so pseudomyxoma peritonei is a rare clinical entity, but that will tend to come back on board exams. It is characterized by diffuse intra-abdominal gelatinous ascites. So it's called a jelly belly. Okay, so basically the patient's present with a very, you know, increased abdominal girth, and when you open the abdomen, there's this gelatinous ascites that comes out literally. And when you look at the peritoneum, you find multiple peritoneal implant that are composed of mucinous adenocarcinoma. And often, this syndrome is accompanied by the presence of ovarian metastasis. So usually the site of origin is an appendiceal tumor. So an advanced stage mucinous appendiceal tumor that spreads to the abdomen and the ovaries and secretes abundant extraperitoneal mucin. It's often mistaken as a primary ovarian carcinomas, and therefore these cases are usually operated on by the gynae oncologist. But then usually careful examination of the appendix will reveal the presence of the primary appendiceal tumor. Okay, so that concludes our lecture on the diseases of the ovaries and fallopian tubes. If you have any question, please do not hesitate to reach out to me by email, and I'll be happy to help you out. Thank you.